Good morning, everybody, or good afternoon, I guess. It's a couple minutes after afternoon already. It's great to have you here as we have our first ever virtual Spirit of the Barrio. It seems like all these events have become virtual. I'm Anthony White. I'm the Director of Community and Government Relations here at Family Health Centers of San Diego. And it's my pleasure to thank you all for joining us today. We're recording today's event, and the recording will be made available via our website early next week. And we'll send you all a link through an email. Since having to cancel this event 6 months ago now, the world for all of us has been turned upside down, but perhaps none more than those working in healthcare. I know we have many supporters of ours who I see on the call today that are in the healthcare sector. And I just want to say on behalf of Family Health Centers of San Diego, thank you for all of you who are working to help our community address the pandemic. It was hard for us to imagine the Spirit of the Barrio without the tent, the networking with colleagues and business associates, and of course the tamales. But you have to admit, the parking was a lot easier today than usual. I miss being able to greet you all in person and chat with folks in the line for tamales, but we'll get back to that decades-old tradition at some point. For now, we've pivoted to today's virtual event, and we're excited to have so many people join us. Our regular guests know we normally start every Spirit of the Barrio event with our roll call of sponsors. For those who are new, we call out all our sponsors, and the guests at the sponsors' tables cheer and shout. Well, I'm happy to tell you that we're not going to try to do that today via Zoom. But because we have such a dedicated family of sponsors that continue to support the work of Family Health Centers of San Diego, I wanted to take a minute to call them out. You all have been extremely dedicated to the work of our organization, and particularly this year. In fact, some of our sponsors even reached out and offered additional financial support without even being asked to try to help our organization fight this crazy pandemic. So rather than shouting and cheering, I'll ask you to tell us which of the organizations you represent as I read off our list of sponsors. If you can, next slide, please. First, we have our Corazon level sponsors, Cox Communications, the Port of San Diego, Rancho Mesa Insurance Services, and US Bank. Next. Our Adelante sponsors, Community Health Group and Scripps. Next slide. Our Fiesta Grande sponsors, we have a big list of them. Aetna Better Health of California, A.O. Reed & Company, Blue Shield of California Promise Health Plan, Imaging Healthcare Specialists, Kaiser Permanente, Mitsubishi Cement Corporation, Molina Healthcare, SDG&E, Sharp Healthcare, and UC San Diego Health. Our benefactor sponsors are Verona Resort and Casino, Coast Citrus Distributors, Edco Disposal, General Dynamics NASCO, Planned Parenthood of the Pacific Southwest, Shore Office Warehouse, and United Healthcare. Our patron sponsors, Aztec Fire and Safety, BAE Systems San Diego Ship Repair, Barrett Engineered Pumps, David S. Tam Financial Advisor at Edward Jones, Patterson Palm, San Diego Firefighters, Local 145, South Coast Copy Systems, and Waxy Sanitary Supply. What an incredible list of sponsors we have. Thank you all so much. Because so much has changed since the sponsors committed to us early in 2020, I wanted to take a minute to talk about the efforts that your sponsorship dollars have helped make possible. Not just helping to fund some of our response to COVID-19, but over the years in keeping Family Health Centers of San Diego strong so that we were in a position to react to the pandemic as it hit. Let me talk about a few of the many actions Family Health Centers of San Diego has taken over the past few months to address the pandemic. Since March, as you can see, we've tested over 24,400 individuals. That number is a few days old, so maybe Dr. Ramers will have an update for us. But we're doing about 900 individuals each week in testing. We're a significant part of the county's testing capabilities here at Family Health Centers. Our focus has been on the community's hardest hit, and I know that Dr. Ramers will talk about that a bit. Our test positivity rate is double or sometimes even triple than that of the counties, which says to us we're testing in the right places, reaching those communities with the highest level of the disease and working to make sure to identify that and get them isolated or into treatment if needed. FHCSD quickly mobilized to test those experiencing homelessness, and we tested everyone at the San Diego Convention Center that was being sheltered by the city. Here are some pictures of just one of our testing sites. This one is at our Barrio Logan Clinic. We have 4 COVID testing sites right now across the county. Next, please. We never closed our doors at family health centers. We remained open. Some of our sites switched to telehealth, but we remain open, providing quality care. Our mental health services particularly transitioned to telehealth, as the mental health services during the mandated stay-at-home order cannot be understated. And related to our testing, our test sites and labs work diligently to provide test results in 1 to 2 days. We're the only federally qualified health center in California, and we believe in the country, that has our own independent high complexity labs. So we're not reliant on some of the corporate labs that are taking 10 to 12 or even longer, 10 to 12 days or even longer. We have that in-house. Now to the focus of today's event, the COVID-19 pandemic that we all face. With so much information swirling and our knowledge of this disease changing rapidly as new research is undertaken and released, we thought bringing an expert to the table to talk about the pandemic as it stands today and our community would be helpful to you all. Our featured speaker, Dr. Christian Ramers, is an internationally recognized infectious disease specialist. You can see some of his credentials there in front of you. We're fortunate to have him on staff here at Family Health Centers of San Diego with his skills, where he serves as the Chief of Population Health, the Assistant Medical Director of Research and Special Populations, the Director of our Graduate Medical Education Program, and the Medical Director of our brand new Family Health Centers of San Diego's Laura Rodriguez Research Institute. As if all that wasn't enough to keep him busy, Dr. Ramers serves as a consultant to the Centers for Disease Control and Prevention, the California Department of Public Health, WebMD, and Medscape. He's an adjunct professor at UCSD in San Diego State, an education consultant for the University of New Mexico Project ECHO and the Northwest AIDS Education and Training Center. He also chairs the California chapter of the American Academy of HIV Medicine, and he continues to influence infectious disease policy and practices around the globe as a senior clinical advisor for the Clinton Health Access Initiative's Global Hepatitis Program. Today's presentation is a modified version of a weekly COVID-19 presentation that Dr. Ramers provides to several hundred family health centers of San Diego providers, advising them on the latest developments and counseling them on their clinical COVID-19 practices. He also has the great ability, which we're lucky to have, to be able to make this understandable to the average listener like you and I. With that, I'll turn it over to Dr. Ramers.
Great, thanks so much, Anthony. I hope you can hear me okay. Let me know if you can. Okay, great. So welcome everybody. I hope people are healthy and safe out there in these really unusual times. My task here is really to go through some pretty complicated scientific information and epidemiology, and I hope I'll do it in a way that makes it understandable to everybody. I would encourage you to put your questions in the chat. I'm hoping to end a little bit early so we have at least 15 minutes at the end for questions. And I've already gotten about 30 or 40 of them from your pre-submitted ones when you registered. So I won't be looking at the chat as I'm speaking, but Anthony can help manage that for me. So I'm going to start the way I usually do for our weekly or bi-weekly clinician updates, and that is to start really broad at the 30,000-foot view of what's happening globally with COVID. We'll sort of narrow down into California with just a couple of other aspects I thought were interesting. I do want to outline the FHCSD response since those of you who have been our supporters, just to sort of see what your donations and dollars have been doing. I'll touch briefly on some of the clinical aspects like transmission and what this disease actually looks like clinically. And then looking ahead, I know that the theme of this talk was really the road ahead. And I really want to make sure that we all are aware of vaccines and what the vaccine is going to do for us. I don't think it's a question of if we'll have a vaccine, but really when, and it could come really quite soon. And then questions at the end. So hopefully you all have seen some form of this website. This is the Johns Hopkins website, really felt to be the best conglomeration of a lot of epidemiologic data from around the world. And I look at this almost every day. This is actually from a couple of days ago to make the slide set, so it's old already. We are now over 30 million cases globally from this coronavirus pandemic, really unprecedented in terms of anything that we've ever seen related to other virus infections, other outbreaks, that type of thing. But many of us really anticipated that something like this was going to happen. I think most of us thought it was going to be an influenza type strain, but coronavirus it was. And I just want to emphasize a couple of things that we've seen. I put sort of the next top 7 or 8 countries down on the bottom there. Obviously, we all know that the United States has more infections than anywhere in the world. India is close behind, though, at 5 million. There was a terrible outbreak in Brazil that was really just out of control over the summer. That's gotten a little bit better, but still a lot of deaths there. Russia, hard to trust the numbers there because it looks like they've had so many infections and so few deaths, but still substantial, at least over 1 million there. And then I highlighted Latin America. I host a kind of a clinical discussion once a week with Latin American clinicians, and boy, have they been incredibly hard hit. You can see Peru, Colombia, Mexico, and Spain. Spain is an interesting case I'll get to in a second, but really a lot of infections all throughout Latin America, just really having a lot of suffering, a lot of death in many of those countries. Spain, I think, deserves particular mention because it's really a developed, sort of westernized country, and it was very involved in a very strong outbreak in the beginning. In April, you see the red line there are the new cases of COVID in Spain per million residents. We know that the UK or England and Italy and Spain all were hit extremely hard in the very beginning, and then they basically got things under control, really flattened the curve way down to almost nothing. And it's really remarkable to see what that red curve has done more recently. So we saw this historically with the pandemic flu in 1918, that there was a huge first outbreak and then another second outbreak. Actually, within the flu, it was worse the second time around. And then in some cases, even a third outbreak. Spain has now eclipsed us in terms of new cases per million residents. So what happened here? What can we learn from what's happened in Spain? There really was a pretty weak national strategy in Spain. A lot of the management and rules and policy were deferred down to the regional government level, and so they all did their own thing. They reopened prematurely, trying to salvage the economy with a tourist economy that really depends on other Europeans coming in their bars and restaurants. They actually were wide open for business sort of late in July, trying to salvage some of that economy. And then they had really not very disciplined and not very widespread levels of testing and contact tracing. And so you see the cases in the orange bar graph on the top right there, really getting quite out of control in the last month or so. These numbers are up until the end of August. And then the deaths have not quite started up again, but we know deaths definitely lag, usually by about a month from the initial cases. And then one other explanation might be that the older and more vulnerable people in Spain are actually just taking their own advice and staying home, and that these are a lot of cases in younger people. Moving on to the United States, this is what the cases look like just in the last week or so. Really interesting that things have gone from the big urban centers in the Northeast, New York, and then Seattle was hard hit early, and then we had our big outbreaks in California, I'll get to in a second. And it's really moved into a Midwestern and a Southern pandemic. It's really a lot of these states in rural Midwest, rural Idaho, South Dakota, North Dakota, and places that don't have a whole lot of health infrastructure actually that are getting hardest hit. On the bottom, you can see the new cases, big initial outbreak in April and May. That was mostly New York City. A huge influx in July, probably because of reopening too soon. People got sort of, lockdown fatigue, and we opened everything up. That's when we had these amazingly high numbers in Florida and Arizona and Texas, and California, I should say. And then things have kind of cooled down a little bit, but this bottom part of the red graph there, I should say, hopefully you can see my pointer down there, we're still at about 40,000 cases a day. We never really have flattened the curve the way other European countries had. So 40,000 cases a day or so, and then over on the far right, you can see that on September 15th, 39,000 new cases and 1,200 deaths. Really not a good place to be in terms of wanting to reopen even further from where that is. In the gray on the bottom, you can see the death rates. We just got hit flat-footed, I think, most of this being from New York City. All of the death, the entire healthcare system was overwhelmed. It just blew my mind to be on webinars and talking to intensive care unit docs or resident physicians in New York, where their entire hospital was basically converted into a COVID ward. And people were just completely overwhelmed. This is when we had the real fear of running out of ventilators. And I'm aware of places where that actually did happen in some New York hospitals. But things did get sort of better. We saw this downward slope, and then we've had this sort of running almost flat average of about 1,000 people in the US dying per day. Every state is really different, and it's hard to look at a whole state. Really, we need to get down to the local level, but suffice to say, just to look at some states, you can see the Northeast here has really trended very much better. The positivity rates in New York, I'll show you in a bit, are very, very low. Really, that deep red in the middle of the country right now is where the hot spots really are, also extending all the way down to Florida as well. And I've looked at these, a lot of data to look at here, but you can just see that every state is really in a different spot, and it all depends on the policies of that state in terms of testing, in terms of mask wearing, in terms of opening and closing the economy. And the one thing that is for sure is that as soon as you open things up again, the cases are bound to come back. There's really no hope that this is just going to one day disappear. Just to look at California on this particular graphic here, we still see about 3,000 or so cases per day. I think that's down a little bit from this particular graphic. And our positivity rate is about 3%, so things are looking relatively good because of the shutdown really that we had late in the summer. And I highlight here in the red circles just several other states that are really not under control at all. You see Alabama with about a 16% positive rate, really impossible to do any contact tracing there. Florida, Georgia, and Iowa all sort of close to 10% or higher in terms of positivity rate. And then the Dakotas, South Carolina, South Dakota, and Texas also very, very high. What the World Health Organization considers a goal to have as your positivity rate is about 5% or so. That means that you're sending enough tests to really have a good handle of where these cases are, and that you have at least some hope of contact tracing and getting people to isolate themselves. So moving down to California, and then of course we're going to progress to the San Diego numbers. Really interesting how the outbreak has changed. You can see our big surge happened in July. There were articles written about how amazing the response was in California and how we just completely succeeded at crushing and flattening the curve, as you can see, with the cases being relatively flat in April, May, and June. And then I think we just got complacent. We just got a little bit lazy and a little bit impatient, and we felt a lot of this economic pain and really wanted to open things up. And then we had close to what I would consider exponential growth in July. And exponential growth is what is the nightmare situation of public health officials and people that look at public health, because this disease, as I'll show you, really is transmitted and shows up over about a 2-week period. So if you get to the point where growth is exponential in cases, this can very, very quickly overwhelm the healthcare system. And that's why we've kept such a close eye on our ICUs and our hospital capacity. The chart on the bottom right, I just want to show you, these are the top counties in terms of cases in California. And some of them you may not even recognize. They're rural, Central Valley, largely counties: Kings County, Merced, Madera, Stanislaus, Tulare, Fresno. I just want you to put your eyes on the numbers in the blue squares here. This is a couple of weeks ago, I think from late August, and I'll just overlay what are our current numbers here, much, much lower. So we're in better shape. Let me go back one just so you see that again. 900s, 800s in our top counties per 100,000, and we're down to about 600 or so total cumulative cases or so. So really looking in a much better place in California. You can see the deaths on the top right, a big surge of deaths that followed the surge of cases in July. And it's on the way down, but still, for anywhere from 20 to 100 deaths per day in our state. Here's our San Diego dashboard, and we've had over 40,000 cases in San Diego. We have had about 754 deaths and 791 ICU stays and over 3,000 hospitalizations. Doesn't show up all that well in this graphic, but really the South Bay was the source of a lot of our early infections. Very, very hard hit in the South Bay. And now it's really kind of widespread, I would say. Most jurisdictions and most zip codes in the county do have at least some COVID. One other thing I'll point out here is the ICU rate. Of all the cases that we see, about 1.8% of people end up in the ICU, and almost all of those people die. So 791 people have entered through the doors of an ICU in our county, and only it looks like about 40 of them have walked out. So by the time this disease gets to the point where people require intensive care, it's almost too late in many cases, and that's where all the death is happening. You can see the hospitalization rate is close to 10%, about 7.7% of those cases that we know about. This is a graphic that combines the testing capacity that we've built in our county, as well as the positivity in the orange bars, and then in the testing positivity rate, which is the combination of those two. And I think this shows a number of things. The first is that we've done a really good job getting our testing capacity up to over 6,000. That was the goal. I sit on the county's lab testing task force, and early on, when we were just struggling and sending samples out to LabCorp and Quest and then waiting weeks for the results, we were just sort of waiting until we could get better lab capacity, really as a prerequisite to know where the epidemic was. This is absolutely critical to know what's going on in our community. It's like fighting a war without any intelligence, really, is how I equate it. The testing is absolutely essential. And we've gotten to the point where through public and private testing, university hospitals as well as FQHCs like our own, really up close to or above 6,000 tests per day, which is really what we want. And having done that, we have a positivity rate around 4%. That's the purple line that you see countywide. And then the orange numbers there are just the numbers of cases. And really, if you look at this, it's just things going up and down and up and down, not really a major trend, just sort of a flat trickle of ongoing cases. I will mention, as Anthony said at the beginning, that in our clinics in the South Bay and really throughout the federally qualified health center or community clinic system, and this is true for my colleagues that are at San Ysidro and Vista Community Clinic and Neighborhood Health and Father Joe's, community clinic testing rates have been way above this. We've seen it about 10 to 15 to even 20% positive, which, as Anthony said, really shows us that we're testing in the right places and we're really involving and caring for a very highly impacted group of people. So let's get to the state shutdown and opening system here. So this is actually really important for us all to understand, and it may impact San Diego County as early as next week. So the state has come up with a system. This is after the exponential growth of cases in July and after our death rates got so high. They came up with a reopening system that was much more careful, much more cautious, and much more based on data. There are 4 tiers. They initially named them tier 1, 2, 3, and 4, but it was that 1 was the worst and 4 was the best, so it was a little bit confusing. They've gone more to just the color-coded here designation. So you have widespread transmission, substantial transmission, moderate transmission, and minimal. And they're based on 2 metrics. The first is the number of cases per 100,000 population. And you can see the goal there is to be less than 1 per 100,000. That's about where New York City is. 1 to 3.9 gets you in moderate, 4 to 7 gets you in substantial, and more than 7 gets you in widespread. And then the second metric is the test positivity rate. And these 2 things really can give you a pretty good sense of what the outbreak is doing in your particular county, whether the measures that you're taking in your county are working, and whether you have an adequate enough testing apparatus. Interestingly, I put a little asterisk on the cases per 100,000 metric there. Over on the right-hand side, you can see there's actually an adjustment factor based on how much a county is testing. So an incentive put in there right by the state to say that you really should be doing a whole lot of testing to know what's going on. There's all kinds of really complicated rules that govern where counties sit on this, this tiered system. You have to stay in a tier for a minimum of 3 weeks. You can move down a tier if 2 consecutive weeks you have really good-looking numbers in both metrics, the cases and the positive rates. And you have to go up a tier if either metric is worse for 2 consecutive weeks. The reason there's that 2-week delay in there is really because that's the speed of this epidemic. The changes that you make today, for example, if you put a shelter-in-place order in today, or if you put a mandatory mask order in today, you're not really going to see any difference in case rates for about 2 weeks. That's just the way the disease works. So let's look at some of these numbers. I know this is incredibly complicated and busy slide. It's been confusing because the state actually changed their color scheme just slightly. You can see the tones are a little bit more muted on the bottom. And then this chart, which I, again, look at every week or so, I highlighted in a little red circle over here the important things on the right. So you can see San Diego next to many other counties there. The first is to say that our overall tier initially was in the red zone. They used to call it tier 2. San Francisco is also in tier 2 when this whole system started in late August and early September. But many of our neighbors, Riverside, San Bernardino, I think Imperial is also in the purple in zone 1, which means widespread transmission. So looking over to the right here, you can see it's a little complicated because there's unadjusted and then adjusted case rates based on the number of tests that we send. But our unadjusted rate was 6.9 per 100,000. And then adjusted, that actually was 7.9, but there's been a dispute between the county and the state about how many tests we actually do. You can see that number there says 133. The county believes that we do a whole lot more than that per 100,000. So that's why they allowed us to stay at that 6.9 rate, which, to be honest, back on September 8th was already towing the line of getting into the purple category. Fast forward to September 14th, these numbers are released on a weekly basis every Tuesday. And you can see that our number is now unadjusted at 7.9. And then if you adjust it, it goes actually to 8.1. So we're well above the case rate that would be allowable to stay in the red zone. And this is what everybody is concerned about. You've seen it in the press of us moving back into purple. Why did this happen? Well, one of these curves does not look like the other, like I used to see in the kids shows when I was little. San Diego State zip code really has seen an explosion of cases. 750 at least that have been reported from the 92115 zip code. The numbers are counted as a whole county, and so this is what's been really pushing up our rate over that 7 threshold. I have to say that before this even happened, we were at 6.9, so it's not like it was a major slide, although factoring in San Diego State cases certainly pushed us up to there. And what the county actually did is ask Governor Newsom to exclude those cases, and he just said a flat out no, and the health secretary of the state of California did as well. I can imagine that if cases were inside a very tight bubble, like the Major League Baseball players or the NBA or something, that would make sense. But these students are really living off campus. More than 75% of these cases have not been in student housing. They've been out in the community. And so we really need to accept the fact that San Diego State is part of San Diego, and there is potential for these cases to continue with ongoing spread. I hear from the public health officers team that's on the ground there that initially there was a 20% test positivity rate that is now decreasing significantly. So things are looking good, that we are sort of bending that San Diego State curve down a little bit, and hopefully we'll be on the other side of this very soon with the measures they've taken. So the question is, why can some things stay open and others close? Have they really thought this through? And I actually think the answer is yes. They have based these decisions, this is from the state website here, on basically the best science that we know. Activities and businesses that have a lower risk of spreading COVID are really allowed to open sooner. You might be able to find some exceptions or some problems with this reasoning, that's fine. But overall, things that can accommodate mask wearing at all times are better. Things that allow physical distance, things that can limit the number of people in a dense area, that limit the time a person is there, limit the exposure, limit the mixing of people. All these things are how they've made their decision. And when you think about it, going shopping by yourself with a mask on is a lot lower risk than going to a restaurant with a whole bunch of people where you have to take your mask off to eat or drink. That's just what the science has shown in terms of how these things transmit. Indoors versus outdoors is also a huge difference. It looks like from modeling work that being outdoors or being indoors is about 19 or 20-fold more risky in terms of COVID transmission, which is why you've seen most restaurants start to move outside. Now, is this really based on science? The answer is absolutely yes. This is from the MMWR, one of the publications from the CDC that puts all these epidemiologic papers out there. This is a case control study from all over the country, 11 different clinics that are surveillance clinics for influenza. They had 154 cases of COVID, and they compared to 160 controls. And then they basically do a detailed epidemiologic history of these people and say, where were you in the last week or so? And looked at their behaviors. What they're showing here in this chart here on the right is an odds ratio, which means that if your odds are double or triple between the cases and the controls, you'll see that dot and the bar move over to the right. If your odds are exactly the same as the controls, meaning it didn't really matter, it wasn't really a major risk factor, it'll be right on that dotted line. What I've highlighted in these little red asterisks here are restaurants, bars, and coffee shops that give you literally, I put the numbers there, a 3-fold higher risk of getting COVID or a 4-fold higher risk of getting COVID. This is absolutely why indoor activities and activities that involve eating and drinking and having to take your mask off are considered high risk. Notice the yellow stars as well there, where gyms are listed and churches and religious gatherings are listed there. Those give you about a 2-fold risk. In terms of the statistics, it wasn't statistically significant, so it's not sort of such a major risk known from this study. But we do know that being in a gym and breathing heavily is going to be a factor for expelling more droplets that are going to be more infectious. And then we've known of quite a few major super spreading events where 10, 20, 30, 40 people get infected in religious gatherings that are indoors with people singing. And so this is what the whole system is based on, is the facts, basically what transmission is like and how do we keep cases down. I saw a question that came in the registration about schools, and I certainly don't have time to go through all of the complexities that have to do with schools, but just to let you know, schools are essentially tied to these color-coded things, but loosely, meaning that a school has a little bit more freedom in terms of staying open or being closed, related to those color-coded things that I mentioned before. But this just came out on the 15th. So 2 days ago, the CDC finally put out indicators of when it might be safe to potentially open a school based on community transmission numbers. I think it is possible to open a school in a community that has very, very low transmission, as long as they have met these metrics and they're in at least one of those green zones, which we actually are, and the school is able to implement these 5 key mitigation strategies that are listed there: mask using, social distancing, hand hygiene, cleaning and disinfection, and contact tracing. So the question was, is it possible that schools might open before a vaccine? I think the answer is yes. Depends entirely on community transmission. Look, all over the world, other countries have successfully opened schools in some situations when they have controlled the community transmission of this disease. Look at Asian countries, look at Germany, look at other places. There are also examples of it going completely wrong, like Israel, where they have had school-based outbreaks because they probably opened too soon and their numbers were not low enough. Here's some secondary indicators here that I'm going to go through just very quickly, just to say that it's very complicated to know whether it's okay for a school to open or not. I didn't know where else to put this in the talk, but I felt like I couldn't give a talk about COVID without talking about racial disparities. So these numbers are from the state of California. I'll show you San Diego's numbers in a little bit. Latinos and African Americans have been disproportionately impacted by this disease. I can theorize about some of the reasons why I think, but just the numbers are stark here. On the top, these are just cumulative cases per 100,000, so normalized to population. You can see Latinos are way up above even African Americans, whites, and Asians in California. On the bottom left is cases, on the bottom right is deaths, with the colored bar showing you the amount of disease and the gray bar showing you population percentage. So if you're not lined up between the blue and the gray, that's a health disparity. And look, it's almost twofold in the Latino community there for cases and deaths. In our San Diego numbers, it's just as striking. We have cases on the top and deaths on the bottom. Keep in mind, Latinos make up about 33% of the San Diego population in the county, and yet they make up double that, 62% of our cases and 48% of our deaths. The reasons behind this, I think, are subject to a little bit of speculation, but there's been plenty of work. I took the slide out at the last minute, but the Los Angeles Times has done a really detailed analysis of different industries, different essential workers, what percentage are made up by Latinos. And if we look at farm working, we look at food service, we look at janitorial essential workers, people that have been basically forced to continue to work throughout the pandemic, much higher proportion of Latinos. They also have a lower ability to be able to work from home and work remotely. And the kicker, which there's been some press about this in the Union Tribune, also the most likely to be sort of losing their jobs. So really, really disappointing and major disparity. I'm going to move quickly because I see that I'm running a little bit behind in time and talk about the Family Health Center's response here. So really, it's all been about testing, testing, testing. That was one of the mantras early on that public health experts said was really essential. Just to get the basics out there, we're talking about testing that's diagnostic testing of people that might be sick or might be asymptomatic carriers. That's where the sort of virus itself is detected here on the left-hand side. There's also serologic testing that is a little bit less important, I think, but also something that we offer. That's when we look for antibodies over far on the right, many, many days after symptoms. Important to know that there's a really discrete window when diagnostic testing should be used and really can detect infection from about 2 days before symptoms to about a week after symptoms. And then serologic testing really shouldn't be undertaken until about 2 weeks after you think somebody's had the disease. So Anthony touched on this a little bit. We were able to start in-house testing in our high complexity lab as early as April, on our Abbott M2000 machine. Initially thought we could run 80 tests per cycle and close to 200 per day. Somehow we were able to get up to almost 400 tests per day with a turnaround time that was less than a day in most cases. We've offered testing throughout all of our clinics. And then we started this idea of offering walk-up testing or open access testing, first at our Logan Urgent Care, and then eventually at 3 additional sites and then additional rotating sites throughout the county. We've also undertaken a massive testing effort of the unsheltered at the San Diego Convention Center, as well as other homeless shelters, really, which was quite innovative and controversial at the time, using a self-collected technique. And then we have testing for OB patients that are about to deliver babies. Pediatric testing have really worked through a lot of this. And then we brought on antibody testing because it is a useful tool in some settings. You can see some of our providers over there on the right with full PPE, thanks to having a good supply there. I'm told that they were hugging and touching each other before starting a shift, which is okay, before they had any contamination, but really great volunteers that were out there, and we actually did some extra hiring of clinicians to be out there. Now, with respect to shelters and homeless population, we started seeing these publications come out. This is, again, from the MMWR. And I direct your eyes to the red circle in the middle here, what happened in Seattle, Boston, and San Francisco, where some of these homeless shelters, by the time they were actually starting to test there, they found 17, 37, 36, 66% positive rates, which tells us there were these massive outbreaks in congregate living settings. There was one place, Atlanta, where they actually started the testing before they had any diagnosed cases, and they had a very, very low rate. So they did preemptive testing of these large high-risk populations. We saw this, we saw our ability to do testing and said, we have to offer this to the convention center. We have to do wide sweeps of asymptomatic screening in congregate living settings to avoid an outbreak. And that's exactly what we were able to do. This is data that is going to be submitted in a manuscript, actually, I think today or tomorrow, in collaboration with Father Joe's and the Alpha Project and Veterans Village, the city and the county. And we also extended this to many other places, PATH, Downtown Connections, the Rescue Mission, Salvation Army, McAllister, and House of Metamorphosis. I think I remembered all of them there. Basically mass sweeps of testing of asymptomatic people. You can see the numbers there. What does this do? Well, it allows us to find the very small number of positive cases and isolate them in a hotel room the way the county has wanted us to do. Our positivity rates in these sweeps have been less than 2% in all these cases. And in my opinion, we've saved ourselves from a disastrous outbreak in these populations. So kind of a unique strategy and unique way we were able to serve our community because of our testing capacity. I'm just going to zoom through these visuals really to show you what it looks like from where we sit. The green line graph here is the number of tests we've sent. The red on the bottom is the number of positive cases. So quickly ramping up our capacity all the way up to about 200 a day. You can see our positive rate is about 11%, really from the beginning. This is from June. I'm going to fast forward to the end of July, where our positivity rate went way up to 20% in some cases. Our capacity also went way up to almost 400 tests a day, and really responded to the surge that happened in the summer. And then here we are settling down a little bit more in September, where our positives are still about 18 to 20 positive cases per day, still at about 10% positive, but our numbers are definitely on the way down, still 200 tests or so per day that we're offering. I would anticipate that this actually is on the increase as schools start to reopen and things start to reopen. Here's the positivity rates from our tent testing sites on the bottom, anywhere between 10 and about 13 or so. And just some demographics about those that have been found to be positive in our setting. 233 homeless individuals diagnosed with COVID in our clinics or in our tents, successfully able to isolate and not pass on that infection to other people. And then again, just to reinforce, this was presented at the county slide briefing at one of their press conferences, different entities and different test volumes and then turnaround times. And you can see on the bottom there, the FQHC clinic, we're the only one that's doing the testing ourselves. So that's us. 134 tests per day on average and a turnaround of less than a day, which we're very, very proud of being able to offer. This is our antibody testing. I'm going to skip through this, except to say that it is a really useful test. And if you think that you've had COVID in the past, I would suggest you get one. We've been using the Abbott Architect, which is a 99% specific and 100% sensitive for diagnosing infection. We're also following all those patients that are positive through a registry, and this is, serves a couple of purposes. It really allows us to give the social work and case management that might be needed for people that might lose a job, might need to be followed up, might need a meal, might need housing, might need to isolate. It's really an incredible feat of our IT department. And as we go through, we've seen people get recovered. That's the green bars there. And then we're actively case managing at any given time about 180 to 200 people. You can see during the surge time in July, that was up to about 600 people. So things have settled down a little bit. Our outcomes we're very interested in tracking here. We've had an ICU admission rate of less than 1%, a ventilation rate of less than 1%. Unfortunately, 5 of our patients have died. And many people that I've seen in clinic have been able to recover, but have long-term kind of sequelae that we're following. And then it goes way beyond that. There's been a whole lot of other things that we've done in terms of policy development. We participate in these biweekly clinician updates. We participate with the County Health and Human Services Agency on a community call that's every week. I'm a member of the Laboratory Testing Task Force, the Equitable COVID Recovery Task Force. I was part of a group that went to Tijuana with the San Diego County Medical Society and UCSD to help them prop up their intensive care unit there. And as you can see, other things that we've been involved in at the CDC level, as well as other things in the media. just trying to get the word out there to contribute to the narrative, which of course, if you don't get out there with scientific facts, it can kind of get out of hand. Okay, quickly, just a couple of minutes on the clinical aspects of this disease. We've learned a lot about transmission. Initially, it was thought to be only within about 6 feet that this could transmit, moderate-sized respiratory droplets, really from people that are symptomatic. It turns out that wasn't true. We now know for sure that asymptomatic transmission occurs, and probably transmission occurs over a longer distance in more of a rare setting. So if you're in a building that's closed and has poor air circulation, this is really when aerosol transmission plays more of a factor. That's why the restaurants are associated with more transmission in an indoor basis. This is a study from Seattle showing you that from the time somebody develops symptoms on that red line, there is transmission well before the symptoms and then for about a week afterwards. So we know for sure that asymptomatic transmission is likely. Part of the reason why we wanted to be testing asymptomatic people. In this particular study, most of the nursing home residents actually became positive, but 50% of them were asymptomatic at the time that they were tested and obviously transmitting to other people. So again, we've learned a lot about masks. Many different studies show that masks work. As the CDC director said in front of Congress just yesterday, masks are really the one most powerful weapon that we really have. And I think they will continue to be even after a vaccine comes, but plenty of evidence where masks have been implemented that they show really good efficacy at declining the rate of transmission. We jumped on this right away and initially in March, it looks like, put on a universal masking policy for all patients coming into our clinic and all providers. And we had very, very few transmissions in our clinic. I'd say one of the safest places to be actually in this era. The course of the disease looks like this, and people don't usually realize this, that this is a long or a subacute course, meaning that you get exposed on the far left. It takes on average about 5 days up to a record of 14 days to develop symptoms. Usually it's about another 2 or 3 days before you can go get a test to see that you're positive. And then there's this yellow sort of honeymoon period of 7 to 10 days where you may feel okay, you may eventually recover, but some people actually decompensate after about a week or a week and a half. And that's when people tend to get hospitalized. From that time, it's usually another 2 weeks before people die. And then their lungs look like this on the far right-hand side. So you count all the days up, this is about a month from the time a new case happens to when a death might occur. And it's about 2 weeks before when you'll even detect a case from any changes that you've made. We think that there's really 2 phases to the disease, really a viral phase that dominates in the beginning, and then an inflammatory phase in the second half. And the medicines that we have really work differently in different parts. In terms of the mortality, this is the initial data that came out from China. Although the disease is kind of a normal distribution throughout the population by age in the blue columns, as you can see here, the mortality is clearly much higher in those that are older. So in this case series, 16% mortality in those over age 80, and then down from there. In the UK and in Spain and in many other series, that's actually been much higher, closer to 40% mortality in the oldest people. 80% or so have a mild to moderate disease, 15% or so have a severe disease, and 5% tend to have critical disease. Strongly influenced by age, but also by underlying conditions and comorbidities. And one big surprise in the US has been the presence of obesity. So this is the first reports that came into the CDC. In the 20 to 44 age range, we had a ton of hospitalizations, a lot of ICU admissions, and even some deaths, mainly driven by the obesity in our population, which is about 1/3 of Americans are overweight and another 1/3 are obese. So a major factor in the course of the disease in our country and possibly why we've had so much death. What about long-term symptoms? This is another study from the MMWR showing in the light blue columns here what symptoms look like when people presented, and then in the dark blue what things look like 21 days later. So you can see many, many people still having things like fatigue and cough and headache and body aches well beyond the time when they're out of the hospital. This is not a benign little flu that just kind of goes away. People have suffered for weeks and months, and there's now even a recognized syndrome called long COVID, where people have almost chronic fatigue type symptoms over the long term. Not exactly clear what's going on there, but we do know that COVID can affect the heart pretty profoundly and perhaps cause a heart infection as well. We only have a few medicines that are really available. I listed them here. Remdesivir is an IV antiviral. Dexamethasone is a steroid that we give in the hospital. Oxygen helps. This thing called pronation helps as well. And then convalescent plasma has helped. These are all for hospitalized patients. And I put a big empty circle there. We really are limited in what we can give to outpatients. So Many trials still looking at what can be available there. And we're actually thinking of getting involved in some research trials to try to find those treatments as well. Here's just a big list of what's out there. The top 3 up there have been approved by the FDA. And then other medicines here looking at potential reduction in hospitalization, those types of things. Unfortunately, we've had many sort of try and fail type things like hydroxychloroquine, oleandrin, ivermectin, an antiparasitic, and lopinavir, which is an anti-HIV drug. But these are now being worked out. This is how science works: is we test things, we find if they're efficacious or not, and then we kind of move on if they're not. One of the most magnificent and mysterious parts of medicine, in my opinion, is the human immune response. And we are just now learning about COVID immunity. We have T-cell immunity, we have B-cell immunity on the bottom here. And what typically happens is you'll have, after exposure, really the development of antibodies and T-cells. And then these things kind of settle down through time. And what we're banking on is over on the right. Now, people will have some form of longer lasting immunity and be able to have what's called an anamnestic response if they get challenged again by the actual disease. It looks like this lasts at least 4 months in most people. Reinfection has been described as extremely rare. Out of the 30 million people in the world that have had COVID, there's only been just a handful of reinfections that we know about so far. It may be that the longer we go, that people's immunity kind of fades and we'll start to see more of these, but it seems to be an extremely rare event at this point. And mimicking this response is really what we're trying to do with the vaccines. So I know I'm a little over time. I'm going to finish with the vaccines and then get to your questions. Why do we need vaccines? Well, I just want to show you one curve that's directly from San Diego hospitalization data. When we reopen society, we have exponential growth. When we close society, we have falling of that growth of cases. This is going to happen over and over and over and over again. And you might say, well, why don't we get to herd immunity? This doesn't make sense. Aren't people immune from this by now? Well, you'd like to think so, but the data suggests otherwise. These are serologic surveys from many states throughout the country, all the way through June, end of June. And the only place where you're even anywhere close to herd immunity is the 20% rate that you see in terms of antibody positivity in New York City. And even that is not close to herd immunity. To have herd immunity, we think you need 70% of the population protected. We are nowhere near there. In the California numbers that I've seen, the only one that's in here is 1%, meaning that 99% of people in San Francisco are not immune. I think it's probably the same in San Diego. Maybe 95% of people are not immune. So if you want to work on herd immunity, that means you are complicit with allowing millions of people to die of this disease in order to build up immunity in the population. Not going to happen, okay? So that is not a good strategy. We can get to herd immunity through a vaccine, and that's really probably our best hope going forward. So briefly on the vaccine effort in this country, it has been an incredible scientific effort. You can see on the top right, 30, 40, 50 vaccines being tested now, 9 of them in phase 3 trials, which means they're furthest along and may come very soon. There have been 5 in the world that have been approved on a limited basis, but in our opinion, that's sort of the Russian and the Chinese vaccine, which really weren't tested in a rigorous way. On the bottom, I put here that the 3 major candidates that are being tested in the US are the Moderna vaccine, the Pfizer vaccine, and the Oxford AstraZeneca one. And these trials are almost fully enrolled. The Moderna updates their website here in the bottom here. 25,000 people enrolled as of September 16th, so almost at that 30,000. We should have results from these vaccines definitely within a couple of months. I don't think we'll get them by the end of October, but we should get them within a couple of months. We at Family Health Centers are joining in this effort. We are helping to recruit for some of these vaccine trials and really increase community awareness and just get this conversation going. You can see one of our assistant medical directors, actually, Dr. Smoot. I hope he doesn't mind I use the picture. Him in one of these research trials getting the vaccine himself, or at least it could be the vaccine. The website is covidvaccinesd.com, which they're recruiting through, and we have people out there talking to individuals about the vaccine because we're aware that in communities of color and in vulnerable communities, there is an increased suspicion about biomedical research. I'm happy to say that the registry that will eventually lead into these vaccine trials has over 1,000 people enrolled in it, and they've done a fairly good job getting non-white individuals in communities of color. It's not really at our goal. We would love to see at least 30% communities of color and more than that enrolled in here, but 12% Latino and 9% Asian Pacific Islander, at least as of now. We have an email address within Family Health Centers, covidstudy@fhcsd.org, which is kind of the portal for anybody that's involved with our patients at all that wants to talk about vaccines or get enrolled. That's kind of where we're sending everybody. The way we usually do trials is through a very organized and very rigorous process. Phase 1, phase 2, phase 3. That's what gives people like me as infectious disease doctors the confidence to recommend a vaccine to the general population and know that it works and know that it's safe. Some of your questions that came in were about people not wanting to get the vaccine or not trusting how fast things are going. And I'll admit that is a very, very big concern. The FDA will have a meeting on October 22nd. They've promised not to review individual vaccine data at that time because, to be honest, it's not going to be ready. But they're going to talk about EUA or emergency use approval and what's going to happen next over the next month or two. There's been also the CDC really kind of alarming, saying that they want to get ready to distribute vaccines by November 1st. I think that's good to be prepared. We'd rather be more prepared than less prepared, but it seems to be a little bit of an unrealistic expectation because we all want to wait till the safety data comes out. And there's been very strong pushback from the companies themselves and from the Infectious Disease Society of America saying that we cannot cut corners, we need to do this safely, or people will not trust the vaccine. A vaccine that nobody wants to take is going to be completely useless. So we're very aware of this issue. Just briefly on the Moderna vaccine, I just want to show you, I showed you the enrollees here, 25,000 already. And this is probably going to be closing relatively soon, which means we should have data pretty soon, within about a month or two. The AstraZeneca vaccine, you may have heard in the news, was actually put on a pause. And that was because of a single episode of something called transverse myelitis in one of the participants in England, in the UK. There's an entity called the Data Safety Monitoring Board, which is an external board that looks at the situation. They decided to put a hold on to investigate. They've now lifted that hold in the UK, and we're just waiting to lift that hold again in the US as more information comes out about this case. Just so you know, transverse myelitis is a rare condition. It's a neurological condition involving the spinal cord. May or may not be related to viruses or vaccines. It usually happens about 1 in every million people, or 1 to 4 in every million. So it could have been a random event, could have been related to the vaccine. That's why they're being very, very careful. I think this is a good indication that the companies are taking appropriate safety precautions and not pushing these things forward. So then who's going to get the vaccine? Well, there's already been discussion about how to phase this out equitably and to do it in a way that's responsive to the disparities that we've already seen. And this is what it looks like. The National Academy of Sciences and Medicine held this learning or listening session on the 2nd of September. I got to actually make public comments here. And it looks like the first in line are going to be people like me, healthcare workers, first responders, people with underlying and comorbid conditions, and older adults in congregate settings. You heard the CDC director say in front of Congress that the widespread use of a vaccine for the general public will be probably late next year. That gets into phase 4. So we have a long way to go before we have a vaccine that's available for everyone, but it's going to start being implemented, I would say, sooner rather than later. And this looks like it's actually the scheme that we're going to probably use. Notice on the bottom, equity is a cross-cutting consideration. There's consideration across all these phases in each population group that vaccine access should be prioritized for geographic areas, and I would argue racial and ethnic groups that have been identified as at increased risk. And we know Latinos and African Americans are in that group. They suggest using this thing called the CDC Social Vulnerability Index. So I'm going to finish here, and I'm sorry I only left a couple of minutes for questions, but vaccines alone, I think, will be insufficient to completely end the pandemic. I think we're going to be left with masks and other mitigation things for a long time, so we better get used to it. We're going to need something called combination prevention. That means vaccines that are widely accepted, masks, hand washing, still some social distancing, and being very smart about things that we open and that we close. Vaccine development is still, I think, the best way out of the COVID pandemic on a population scale, so we really need to get there. The process is intense, it's politically charged, it depends on massive clinical trials, regulatory approval, and implementation, and we have to have community trust to overcome vaccine hesitancy, or we won't get to that 70% that's needed for herd immunity. The pandemic has revealed disturbing disparities amongst communities of color that we've seen firsthand, which already have higher levels of suspicion and mistrust of biomedical research. And so our challenge, all of us, not just me, but our entire society, is to engage in fact-based communication, sensitivity to past abuses of research, which results in this stigma and suspicion, engagement of the most affected communities, and holding decision makers accountable to be transparent, again, to be fact-based, and to take a careful process that ensures high standards of safety and promotes public trust and ultimately results in equitable vaccine allocation. that answers a couple of your questions that came in of how do we do this? How do we engage these communities? Those are my best ideas. So Anthony, I'm sorry I left almost no times for questions, but I'll turn it back over to you and see if we have time just for one or two. I think you're on mute, Anthony.
Yep, there we go. Thanks. Well, I'll take a couple that came in the chat box. I survived COVID and signed up to donate my plasma through the blood bank, but never got a call. Is plasma no longer being used to treat patients?
Good question. So plasma, convalescent plasma is being used. If you yourself received plasma, there's a law that states that you are not allowed to donate a blood product for at least 90 days. So it may be that you're still within that window and they don't kind of want to take your blood just because of infection risk. But if you're beyond that 90 days, absolutely, the blood bank is still taking it. We're not quite sure in terms of the efficacy. We think it works. We're pretty sure that it's safe. And I can say that in the hospitalized patients that I'm seeing, it definitely is still being used.
Great. Then our friends at BAE, can you comment on the use of cases versus deaths as a more effective metric indicator?
Yeah, this gets confusing because the more you test, the more cases you're going to find. That is true. I think hospitalizations and deaths is actually a more solid number to use. This is changing through time because we've actually gotten better at taking care of COVID. The reason cases is still important, though, is that every case that you see has the potential to affect 3 or 4 more other people, or it could be a super spreader. So in terms of getting the public health control, cases are still very, very important. And high levels of testing all the way down to sort of a 1% positivity rate, like the way New York City has, I think is still really important to control transmission and the pandemic overall.
And the last one that I had in the box was, can you comment on case fatality rate versus infection fatality rate as a way to classify COVID, maybe similar to the first question or the last question, and also comment on CDC death data for under 55 years old versus over 55.
Okay, so case fatality and infection fatality really has to do with what denominator you use. We think we know who dies of COVID. There was a comment, I think, that's been out there about how only 6% of COVID deaths are pure COVID deaths. I think that is absolute nonsense. People that have diabetes that come in and die of a respiratory illness, they die of COVID. They don't die of their diabetes. So the numbers that we're seeing are, in fact, probably an underestimate. 190,000, it may be above 200,000 by now. So that's the death. And then what the denominator would be is either the number of cases that we know about or the number of infections as a society. That's an even larger denominator. So that percentage actually can change depending on which denominator you use. That's the difference between those two. In any case, COVID is higher than flu, I would say, by 5 to 10 fold. In terms of the over 55 and under 55, I think it's a general rule of thumb. Doesn't quite hit the 55 number you asked about, but about 80% of cases are occurring in those less than 65 years of age, and 80% of the deaths are occurring in those over 65 years of age. What does that mean? It means that if you're under 65, you can still die. 20% of the deaths in my hospital here, Scripps Mercy, have been in people under age 50, okay? So it's a very serious disease still. It's just a lower percentage. So you're less likely to die, but certainly we see people in their 20s, 30s, and 40s that die of this disease. But the vast majority of the burden of deaths has been in those that are older. In my opinion, it's just because being older, you're not able to survive the tremendous stress that this disease puts on your heart and your lungs, and you can't survive a 2 to 3 week ICU stay. Younger people tend to have a little bit of a better ability to do that. But as I mentioned, things like diabetes, hypertension, obesity really do make death much more probable in those lower ages.
Okay, I just got one. I know that I said that was the last one, but we got one from our friend Taryn Mento at KPBS, who happens to be on the meeting. She said, I've been hearing a lot about the challenges of patient matching during COVID. I've heard that error rates grow as more organizations are sharing data, which it seems is how our COVID testing network is set up. Can Dr. Ramers comment on how or if patient matching is complicating our ability to accurately tally cases, and share how family health centers or other labs are working to ensure low error rates?
Taryn, complicated question. So matching refers to several different things, so I'm not sure exactly which one of them you're talking about. Matching is used in case control studies where you're trying to find equal patients that are similar to each other to see what a disease does. But I think she's actually asking about tracking patients and not double counting them through the system.
It sounds like it.
Yeah, so I mean, we have fairly good data systems in terms of reporting cases to the county. This has been given a lot of attention since the beginning. In the case where you retest an individual, then you could sort of double count them, but we're actually not recommending that you retest people that are already known to be positive. That was a problem early on. People were getting ongoing tests that were positive for weeks and weeks and weeks and weeks, and we don't really recommend that anymore except in special circumstances. So if anything, Taryn, I think it's becoming less of a problem, and it really just depends on the integrity of our data systems that are generally pretty good. Sometimes we see some breakdowns in it, as you saw at the state level. I think in July, there were some problems there. But really, our public health professionals are doing the best they can to not make these types of mistakes.
Great. Well, I think we'll wind it up then. We're just a couple minutes over. Thanks, people, for hanging out. I'm seeing a lot of comments in the chat box that they're really pleased with the presentation. Just a reminder that email will go out early next week with a link. The PowerPoint and the recording will be posted on our website, so you'll be able to access it there. Thanks, everybody, for joining us. We look forward to inviting you to our next event, whether it's here online or at our Barrio Logan Clinic over tamales. But either way, have a great day, stay safe, wear your mask, wash your hands, and have a pleasant weekend. Thanks much.